So it is 7 a.m. Pacific time in San Diego, California now, or 4 p.m. in Central European time. So time for us to start this webinar. My name is Daniel Sauter. I'm a application science manager here at Sophion Bioscience in North America. And it's my pleasure to host two expert speakers today to discuss or to introduce a cardiac safety workflow from automated patch clamp measurements under physiological conditions to QNet-based in silico prediction of proarrhythmic risk. So we have Patrick Valley, a research scientist at Sophion, and Dr. Randy Rasmussen, president at CytoCybernetics with us today. So before we go into today's webinar, I do have a few housekeeping items that I wanted to bring and discuss. First up is if you do have questions, please do not hold back, shoot them out. We have a chat functionality for that reason on the right-hand side, and you can just post your question throughout the webinar. We'll go over these then at the end of both of the presentations. You'll also find a handout section on your right-hand side where you can download information about the technology that we use here during this presentation today, as well as some of the data that Randy is going to go over later on. I do also want to point out that we are running different polls throughout the webinar, and we do encourage you to participate in these because it is truly important information to us to see where you'd like to see technology develop or where you really see the field move in the next time. So it's now my pleasure to introduce our first speaker of the session, Dr. Patrick Valley. So Patrick has a long history working with ion channels in different organisms and tissues. Before joining Sophion, Patrick was first a postdoc and then a researcher at Harvard University, where he's worked in Bruce Bean's lab, studying voltage-gated sodium channels and their role in pain. He's done significant contributions to the field by, for example, characterizing some of the now FDA-approved modulators of NaV1.8. And for that, he used the QPatch technology and really pushed the boundaries of what is possible with that technology already there. So I was particularly excited that Patrick decided to join Sophion in October of 24 as a research scientist, where he since has really made great impact to many of the R&D projects that we are running here. So today, Patrick will talk about a study that he led together with researchers in Denmark for developing assays under physiological temperatures and some of the tools and features he used for that. So without further ado, Patrick, the stage is yours.
Thank you, Daniel, for that introduction. That was very generous. As Daniel mentioned, my name is Patrick Valley, and I am a research scientist here on the bioscience R&D team at Sophion Inc., based in Boston. And so today I will share some of the work that we have done as a team to develop assays for cardiac safety assessment under physiological conditions, and in particular under physiological temperature. So today in my talk, I will first start by giving the background and motivation for developing this assay. I will discuss the experimental approaches that we took to develop the assay. And then I will share some of the data that we generated at physiological temperature using the hERG ion channel as our model system. And following my conclusions, I will pass it off to our colleagues at CytoCybernetics, where they take some of our empirical data and use it for in silico TDP risk assessment in their model. So I'll start by discussing hERG channels and cardiac safety. The human ether-agogo related gene, or hERG IKR KV11.1, is a potassium channel that's critical for repolarization of the ventricular action potential. The ventricular action potential requires a whole suite of different ion channels, as you can see here in this figure. But the hERG channel stands out as particularly important for the repolarization phase of the action potential. And inhibition of hERG, or congenital issues with the hERG channel, can lead to delayed ventricular repolarization and prolongation of the QT interval. QT prolongation can cause potentially dangerous cardiac arrhythmias, one of which is known as the Torsades de Pointes, or the TDP, twisting of the points. And this is when you look on an electrocardiogram, an ECG, and observe fairly chaotic traces as each action potential begins to interfere with the subsequent action potential. TDP can cause acute sudden death in otherwise healthy patients. And following a variety of these deaths, it was recognized that there was a potential, there were on-market drugs that were causing off-target hERG inhibition, such as terfenadine, estemazole, cisapride, and thioridazine. So these compounds, while they were being used to treat a variety of other indications, were having off-target effects on hERG channels that were causing cardiac arrhythmias. So following this recognition, the International Council for Harmonization, the ICH, implemented a number of policies for guiding drug development programs to ensure cardiac safety of their new drugs. One of these guidelines is the ICH S7B, the non-clinical assessment of delayed ventricular repolarization, which is done through two main phases. The first is in vitro hERG ion channel counter screening to ensure that there are no unknown off-target effects on the hERG channel, and investigation of the QT interval effect in animal models of these new molecules. Additionally, the ICH E14 guidance provided recommendation for clinical assessment of QT prolongation in early phase 1 clinical trials to ensure that there are no issues in healthy patients. For me, this was kind of a curious observation from some of the people who have been at Sophion much longer than I, that hERG pharmacology and this cardiac liability was a major market driver and financial driver for the development of automated patch clamp in the early 2000s. Now several drug development programs needed a way to investigate the effects of their new molecules on hERG channels in a high throughput manner. And so here I can show you some very early data generated on our QPatch system to investigate the effect of hERG on the effect of verapamil on the hERG tail current, which is elicited in this green interval here on the voltage protocol shown in the center top. The tail currents that are elicited by this protocol are shown then in the center bottom, and you can see the dose-dependent effect of applications of verapamil on this concentration, on this current, which is summarized in this IT plot, this current time plot in the lower right-hand side. And I just find this to be very curious for our company as a launching point, because I've joined much later in this timeline, and through the decades, the company has developed new technologies and improved technologies for increasing throughput and access, starting at QPatch 16, QPatch 48, all the way up to our most recent Cube 384 system, where we can now do 384 simultaneous recordings at the same time, and the latest technology of our Ethica M contractility platform, our organ-on-a-chip platform, which would allow a researcher to investigate that whole suite of ventricular ion channels all at once in a single experiment. But that would probably be the webinar topic of another day, if it hasn't already been the subject of a webinar topic. So going back to hERG and hERG channels, it was recognized after about a decade of the initial ICH S7B guidance that hERG block alone does not necessarily predict the risk of TDP. There are some molecules that block hERG channels but do not actually cause TDP or have that kind of risk for cardiac arrhythmia. And this unfortunately led to the premature attrition of a number of drug development programs for molecules that could have otherwise had beneficial therapeutic effects. So it was clear that a sort of more holistic view was needed to investigate the effects of new compounds on the ventricular AP. And so the Comprehensive In Vitro Proarrhythmia Assay Initiative, the CiPA initiative, created then a new set of guidelines for drug development programs. So the hERG channel and the IKR current were still sort of front and center in this paradigm. However, in addition to that, it's recognized that important components such as the fast and late sodium current of NaV1.5 and the contribution of L-type calcium channels were also quite important in ensuring that the new molecules would be safe and would not have potentially dangerous effects on the cardiac rhythm. And furthermore, an important component of the CiPA guideline includes in silico modeling to predict the TDP risk category, which will be covered in detail in the second half of today's webinar. So the subject of a recent application report that our team has put out was to develop a high throughput assay for investigating hERG channels. And in this case, we use the CHO-hERG stable cell line as our model system on the QPatch. And for this application report, we focused on primarily running these experiments with physiological solutions and physiological temperature. Under these conditions, we recorded in a range of 35 to 37 degrees centigrade as required or as proposed by the CiPA initiative. And we used physiological internal solutions. These solutions lack a very common seal enhancer used in automated patch clamp fluoride, which can disrupt intracellular calcium and can then make the translatability to the in vivo system a little bit more nebulous. The CiPA guideline further provides a standardized voltage ramp protocol so that different labs and different investigative groups can be comparing data and sharing, sort of have data that's comparable across different experiments. And there are also strict data quality standards, one of which is for the stability of the recording prior to providing to applying compound, that you can have, for example, at least 25 consecutive sweeps with less than a 10% difference in the measured current between those sweeps. Now, this assay comes with a number of major challenges. As anybody who has performed manual patch clamp at physiological temperature knows, it's difficult. And the high temperature causes a lot of instability in the gigaseal. And instability in the seal resistance can disrupt for instance, the data quality guideline that I just referred to, in that you need to have a stable baseline with less than 10% variance from sweep to sweep. So unstable seal resistance at high temperature is a big problem in these assays. And that's further exacerbated by the lack of a seal enhancer, which could otherwise provide a bit more stability for that experiment. So no seal enhancer and high temperature insulting the gigaseal. These are typically long experiments. So even if you want to do a single concentration, you need to do a control period, one concentration, and the reference blocker that's provided in the guidance. And so you're looking at usually a minimum of a 15-minute experiment, which can be difficult at physiological temperature. Furthermore, hERG cell lines themselves are quite sensitive and hard to work with. They typically have very small currents. They're sensitive to overgrowth, and they can lose expression of the current. The signal to noise can be quite poor. So this is an additional challenge for running these assays, yet it was important to focus on hERG because that is the major liability and the main focus for many of these cardiac safety programs. And all in all, this just leads to very high failure rates and likely a lot of frustrated researchers. So these were the major challenges that we tried to address in this study. So to walk you through what we did, the beginning of this, we worked to optimize the gigaseal and the whole cell protocols at 35 degrees centigrade. which is within the range of the CiPA guidelines. And we applied 35 degrees, and we did iterative pressure protocol screening through the GigaSeal and whole cell protocols to try to find the settings that would give us the highest success rate and the most stable recording through our experiment. The solutions that we used were the Sophion sodium chloride ringers, EC000, and our KCl-based internal solution, IC000, with sodium ATP added. We applied the CiPA-aligned voltage ramp stimulation protocol at 0.2 Hertz, shown here on the left-hand side. This protocol holds the cell at -80. It has a brief hyperpolarizing step to -90 to look for a leak. And then it depolarizes the cell to +40 millivolts for half of a second. When you do that, you can see that there is a current elicited in the lower figure. That's P1 of the hERG current. And then as we go from +40 to -80, we apply this hyperpolarizing ramp over the course of 100 milliseconds. And during that ramp, we get this large outward hERG current that's highlighted here as the hERG peak current. That is the current that we focus on in our study and in the subsequent figures that I'll show you. In these experiments, we performed cumulative concentration response on each cell with hERG tool compounds from low, mid, and high TDP risk categories. So we can perform basically an entire concentration response, dose response experiment on a single cell in each of these, in each well. And then finally, we apply E4031 as a reference blocker for leak subtraction, which is specifically mentioned in the CiPA guideline. So the top level view of our findings was that the most important settings for maintaining the stability of the recording were to increase the negative holding pressures 75% from -20 to -35 in both the GigaSeal and the whole cell protocol settings. This increased negative pressure with the physiological internal solution provided significantly increased success rates in our experiments and helped to maintain the integrity of the GigaSeal through the experiment. We initially tried to form GigaSeals at a sort of intermediate temperature of 28 degrees and increase the temperature from there to see if that would be a strategy that could work. But it often disrupted the seal and did not allow us to perform the cumulative dose response experiments that we were aiming for. However, forming the GigaSeal and the whole cell at 35 degrees led to a higher success rate. But in addition to that, we really we had to reduce the cell positioning pressure. So this is the phase at which the instrument is injecting the cells into the microfluidic chamber of the consumable. There is a negative pressure that is applied to capture a cell from the suspension. And at high temperature, with the default setting of -100 millibar, we observed that the cells often went straight to whole cell. So the cell didn't land on the hole and have time to form a proper GigaSeal. It landed on the hole, and the pressure, instantly broke a hole into the cell, and it went whole cell. And when that happens, the recording is often unstable and usually will not last. So this latter point is very important, and I wanted to dig into it a little further for the existing customers who may be using our technology, because then I can provide a little bit more guidance of what you want to look for when you're developing this assay in your home lab. So the whole cell protocol is key, and really what you want to aim for to achieve a higher success rate is the single pulse break-in. So in the top, you can see these plots are all showing pressure over time recorded in the instrument throughout the duration of an experiment. You sort of see this positive pressure that's initially applied as the internal solution is loaded into the microfluidic chamber. The pressure goes back to neutral as the extracellular solution is added and the electrodes are stabilized in each bath. And then you can see, I know you can't see my cursor, so I'm pointing at the top the top plot. So follow me along on the top plot here. You can see a little bit of negative pressure, this very brief negative pressure that's applied. That is the phase at which the cells have been added. That's the positioning pressure I referred to earlier. So during that phase, the negative pressure is applied, and then a cell is captured, that pressure is released, and then it goes up to about minus 35. During that phase, that's when the gigacele is forming. And after the gigacele hits the membrane resistance value that you've set in the software, it will initiate the whole cell protocol. And what you can see in this top plot is that we have one clear spike of pressure. That is a single, for those familiar with manual patch clamp, that is the single pressure pulse that you apply to break into the cell. And when you do that, you end up with a much more stable recording for the duration of the experiment. And you can see here that we then went on for quite a while in this experiment. What you really want to avoid is what's shown in the middle plot here, where after the cells were applied, in this particular case, the cell went straight to whole cell. The pressure was too much for that cell, and it broke in immediately. And so then, as it tried to relax the pressure, it basically initiated the experiments without going through the pressure protocol for the whole cell. And the recording didn't last very long because the gigacele was too unstable. The bottom case is more interesting. So this is focusing on the sort of latter half of the pressure traces. You can see that multiple different increasing pressure pulses were applied, and a pressure ramp was applied. This is the defaults in the whole cell protocol to try many different approaches for breaking into the cell once you've captured the cell. And this works quite well if you have recordings at room temperature, or if you're recording with a seal enhancer, such as fluoride. But we found in our hands that if the cell needs to undergo a variety of different pressure protocols to break in, the recording would typically not be stable enough for this physiological temperature assay. So what you really want to aim for in translating this assay from the application report to your own home QPatch is this single pressure pulse protocol that is shown in the top plot. So following that optimization, I can show here a table on the right that summarizes some of our experiments. On average, we had 99% cell attached, 92% of our cells formed stable whole cell recordings. And following the experiment, about 77.6% of them, 78% of them passed our quality filters for reasonable recordings. And on average, we had experimental duration of just under 34 minutes. So with all of that time, let me show you now some of the actual data that we did. So here is an example of one of our recordings that was done under control conditions. As I mentioned previously, we're applying the CiPA voltage ramp protocol shown here on the top left. And we're investigating this outward hERG peak current. That current is then normalized within each well and plotted over time, which you can see here on the top right. So here's a cell where we're looking at the normalized current over time. And we've undergoing a number of different liquid periods where we're injecting different solutions. So we start off with 2 saline liquid periods for stabilizing the recording over the course of 10 minutes. And then we apply DMSO control injections at increasing concentrations to match the compound. So these are the vehicle control injections. You can see that the recording is quite stable in DMSO and begins to run down a little bit as we apply the highest concentration of DMSO. However, it's quite stable, and then you can see the application of the reference compound E4031 then eliminates the current and brings it down to 0. In the lower right-hand side, I've summarized 32 of these experiments, where you can see the average normalized current over time and the standard deviation. So in the initial first half of the experiment, we have a little bit more variation as the different cells are stabilizing. And you can see there's an increase of variation as we get to the higher concentrations of the vehicle injection. But overall, across all of our control experiments, we observed only about a 21% rundown, and in general, a lot of stability for over roughly 35 to 40 minutes. So using this assay, now we wanted to measure some tool compounds. And here I can show you an example from one of those compounds, quinidine. This is a sort of broad scale potassium channel blocker. And you can see on the lower left-hand side then, the dose-dependent effect of applying this compound on the hERG outward currents until the current is essentially eliminated near the bottom in the light blue color. And you can see that plotted then to the right-hand side of that as an IT plot. So quinidine is a tonic blocker that blocks the resting state. And so with every increased application, you can see a very, very quick, almost stepwise block of the currents as we go through time. Once we get to the highest concentration of 10 micromolar, the current is essentially eliminated. And then kind of curiously, because then we wash off that quinidine and apply this other compound, you can see sort of a very brief initial recovery in the current around 35 minutes, but then it's also blocked by E4031, allowing you to then measure the leak and subtract that from the rest of the recording. So we repeated these experiments across a variety of compounds, which I'll summarize here in the next slide. So here on the left-hand side, you can see a similar dose-dependent effect on the hERG outward current for 4 of these compounds, cisapride, tafetalide, verapamil, and quinidine. With these traces, then, I was able to plot 5-point concentration response curves, which I'm showing here in the top right-hand side. From each of these concentration response curves, you can calculate the dissociation constant, the midpoint, or the dissociation constant, or in this case, we can refer to as the IC50. And the IC50 then gives you the concentration of the inhibition, of the midpoint of inhibition. And for me, I'm a relative newcomer to hERG pharmacology. I don't know anything about cisapride and tafetalide or anything about these compounds. So it was quite gratifying to then go look at the literature and see what are the calculated IC50s from manual patch clamp experiments that were performed at physiological temperature. And much to my surprise and gratification, the values that we generated in these analyses are quite similar to those that were published in various studies. So this approach on the QPatch seems to generate comparable data to manual patch clamp data that are similarly performed at physiological temperature. However, I'm able to generate a very large sample size for each of these groups with a very short amount of time. So this allowed us to screen through these tool compounds and would allow for subsequent screening of unknown compounds in a relatively short amount of time. So to summarize the first half of today's webinar, the QPatch is really a great instrument for working in the CiPA-aligned initiative. The CHO-hERG assay that we just reported on in the application note provides a great starting point for high temperature protocols. As I emphasized, the most important thing is the whole cell protocol and being able to get a very clean break-in for a stable recording. So use the settings that we provided in that application note, look at the pressure traces and see if you're observing the single pulse break-in. And then if you're not, or you're struggling with that, you can reach out to your application scientists who can help provide more guidance about how to achieve those clean break-ins for a stable recording. We performed cumulative concentration response experiments of up to 5 concentrations per cell, which allowed us to calculate IC50 values and get a lot of data for each and every successful recording that we had. And these IC50s are remarkably close to the published manual patch clamp data that we found in the literature. And I finally just want to conclude, I think that really the QPatch, the glass microfluidics, and the custom pressure protocol for each well really allows you to get a high fidelity recording under these physiological conditions. And as we found, gives a great approximation for manual patch clamp. So with that, I will hand it off to our colleagues at CytoCybernetics, who then used this empirical data from this study to perform in silico modeling with the hERG data to allow for TDP risk assessment of these tool compounds.
Thank you very much, Patrick. Really impressive data there. It's really a pleasure to see that. So quick reminder for everyone before we go into the next session here. You have the possibility to ask your questions if there are any in the chat functionality. Just post the question and we can then go over them at the end of the webinar. So it's now my pleasure to introduce the second speaker of this webinar, Dr. Randall Rasmussen. So Randy is a professor at the University of Buffalo, where he holds appointments in both biomedical engineering and physiology and biophysics. Randy's research combines electrophysiology, ion channel biophysics, computational modeling, and drug discovery with a particular focus on understanding the mechanism that govern cellular excitability and cardiac function. In addition to his academic career, he also helped translate scientific innovation into industry through his leadership at CytoCybernetics, where he's currently the president. So today, as Patrick mentioned, he's going to talk about the digestion of some of the high-quality automated patch clamp data in an in silico model. So I'm looking forward to that. Randy, the stage is yours.
Well, thank you very much for that nice introduction, Daniel. And a particularly nice thank you to Patrick for all the work he's done getting things optimized so that you have the really high quality data that makes our particular approach work with automated data, work, as Daniel said, digestible. So today I'm going to be talking about the extraction of scores, actually, to tell you what the safety risk is for torsadogenic potential, as Patrick outlined. So using this automated data. And this software is the CyberQ software. We start out with the experimental data, in this case, obtained with the step ramp protocol. And this digestion, as it were, goes through a series of steps that are all necessary to evaluate how all of the various factors of these multi-ion channel blocks, the complicated sort of interaction between hERG and drug and its very complicated time dependence actually come out as a risk for Torsades de Pointes, with two sort of key things here: a QNet metric, on which the TMS score is based, and the TMS score stands for Torsade Metric Score. So Torsades de Pointes, as Patrick pointed out, is a really life-threatening arrhythmia. It's a real common hazard with all small drug molecule candidates. It causes, it can result from excessive QT prolongation, and IND submissions require safety data on this. And the approach of simply using static hERG block was fairly unreliable and required very high safety factors, sometimes 30x, in order to be taken as safe. And this resulted in a lot of pain for the pharmaceutical industry, and the pharmaceutical industry, in conjunction with the FDA, initiated now quite a while ago the CiPA cardiac in vitro proarrhythmic assay. And it's an approach that takes these multiple ion channel data and puts them in a computer model and analyze it as part of this complex system of repolarization. And it's intended to be a faster and safer path to IND approval. And at the core of it, and what I'll be talking today, is the TMS score. And so this is a number score developed by Jiwa Li, Wendy Wu, and their group at the FDA as a result of CiPA. And it gives you a single number that gives you a repolarization reserve, or a net measure of the amount of charge that's moving during the cardiac action potential. So this cardiac action potential is simulated under various forms of drug dose, and its behavior is evaluated mathematically to give you a QNet score. And this QNet score in turn is analyzed. But there are a lot of steps to go through in doing this. The QNet analysis software is designed to keep careful records of this, to do workflow, to do quality control, to evaluate data that may not be in the protocol initially identified in the FDA software, and do file type conversion. So going through the CyberQ, what does it do? Well, it analyzes these multiple in vitro ion channel measurements. You take simple block models of multiple ion channels. Originally, there were several. The focus now is narrowed down onto the fast and late components of the sodium current and the calcium current. And then really key to the whole thing, and one of the biggest impediments to using it, is to develop state-dependent Markov models of hERG block. Why do you need these? Well, hERG is sort of the key to all of this. It's the major player in arrhythmogenesis, and it shows gating behavior. Gating of a molecule undergoes large conformational changes, so its affinity for a particular drug can change a great deal during a pattern of voltage electrical activity. And this means that it is sensitive to exactly how you're repolarizing. So we use a state-dependent model of high KR block as essential to this, and evaluate it within a human ventricular action potential computer model. The O'Hara-Rudy model is modified at the FDA. And from this, you get a QNet score, and you do this for 4 different levels of maximal patient exposure, 1 time, 2 times, 3 times, and 4 times. And then the average of that gives you your Torsade Metric Score. And all this was released as an R script by the FDA as part of CiPA. But it's not really been widely adopted, largely because, well, the FDA release is it's in R script code, or it's on GitHub, but it's computationally extremely demanding. When we first started out, simulations were taking up to a month on a PC. We've increased that with our CiPA our software, QNet software, down to a day or 2. The FDA release has none of the whistles and bells for workflow, monitoring, quality control, and various other things that you need to do. And it runs one protocol, the Milnes protocol, and that proved to be fairly infeasible. What's wrong with the Milnes protocol? Well, it was developed in Jules Hancock's lab to demonstrate something completely different, biophysical trapping of compounds, just to prove that that was what was going on with them. That as the channel changed its conformation, some compounds were getting trapped inside, others had to unbind before the channel can close. And so it's not really designed for the purpose it was employed. And it's rather difficult. It takes a long time to complete. It has 10-second exposure, or depolarizing pulses, and a lot of controls are needed. And because it's during one pulse at a positive potential with hERG showing inward rectification, it gives you a small current, gives you data only at 1 voltage, and therefore, because of that and the time that it is a limited relationship to the action potential itself. And so this has been replaced, as Patrick described, with the ramp step protocol. So the ramp step protocol gives you a lot of advantage. It sort of resembles a cardiac action potential in shape. It's simpler to implement in that you only have a series of these going on, and therefore a lot of the controls are sort of intrinsic as you watch the time course of it for say perfusion times. And it has a much larger peak current. That's because it's not a steady state current. It is in fact a dynamic current occurring at a particular time, and it's now over a range of voltages. So in theory, this should be much better and carry more information for the block model. Here, don't be intimidated by this. This is the hERG block model that's being used by the FDA. If you look from I0 and open without a star, to the left, all of those are the gating of the actual hERG channel as implemented in the software. And then on the right, there is a series of states indicating blocked channels, ones that are bound in order to reproduce things. And so our exercise here was to show that the step ramp protocol that is currently being used actually contains enough information to constrain this model so that you get a good definition of it. And so being sort of the computer analysts that we are, we start out with simulated data. Now, this isn't completely simulated data. We use the models of hERG block that's published parameters. So each one of the CiPA compounds had a hERG block model associated with it. We can simulate that in real time with our CyberSite dynamic clamp system. And so we're actually doing this in real time. And the advantage of that is then it goes onto our patch clamp rig as an actual patch clamp experiment, complete with capacitance, transients, 60 cycle noise, any little ground faults, and the problems of data. And to this, we can apply step ramp protocols. And because we're looking at hERG primarily here and want to establish that the hERG model, which is close to 90% of the predictive ability of the CiPA initiative, we used the published block data for the other ion channels that was in the FDA data for comparison. And so when we did the simulated step ramp protocol, we get our TMS scores. The TMS score here, Milne's protocol TMS, this is the FDA published Milne's scores for the 12 test compounds in the CiPA panel. On the y-axis here, we have the step ramp protocol that was employed against our simulated models of the FDA models. And what we see is what you put in is what you get out. You get a really close identification of the TMS score across a wide range for the step ramp protocol relative to the Milne's protocol. So the step ramp protocol can now at least has a theoretical basis that demonstrates it can be used to obtain TMS scores. But proof of the pudding is in the eating, and that means experimental data. And here we're very lucky to have that high quality data from Patrick and his collaborator in Japan to give us a great deal of good input file of data. And from that input data, we have to convert it into appropriate structures. And for each concentration, we have to do some initial quality controls. Our standards are a bit higher than the minimal standards of the FDA in terms of that, because we're fitting a model. It's very sensitive to certain things. We have to make sure that we normalize the number of sweeps. We then go through quality control to eliminate unusable traces. And a lot of these are pretty obvious. You got large or unstable leak currents. You have leak currents that shift to positive, possibly through junction potential problems. And then every patch experiment knows that you occasionally get aberrant traces, things where there's just a glitch, something that pops up in the middle of it, excessive noise that comes as a burst, maybe from some piece of equipment being turned on somewhere else in the building. And then we have to remove those. Then after that, we remove the endogenous hERG currents using reference compound subtraction. That turns out to be a very important thing. After we've done all this quality control, we can then start to calculate the detailed hERG block model. We bring in the IC50, in this case it's published from it, and we generate in silico action potentials using the O'Hara routing model. This gives us our QNet metric for each dose, and then we calculate from that the TMS, and we use resampling as done by the FDA to give a certain uncertainty levels of how sure are we that this TMS score is correct, and then that gives us a determination of risk category. Just to give you an example, one of the things that's sort of peculiar that you would run across and maybe not correct such as easily is you have a leak at -80, and this leak is positive. Now, people who do manual patch would look at this and know, oh, there's something seriously wrong with my electrodes. And that can increase during the course of an experiment. That would be something that you wouldn't see. You don't see outward current at -80. And so it provides a larger current in the presence of dofetilide as this is increasing and this polarization is. And so you can get strange things like looking like there's an agonist effective drug when there is not. And so such traces have to be eliminated. And there others are sort of obvious as well. So we got to these compounds. The CyberQ-TMS score was going to be evaluated for 8 compounds. We have 6 CiPA compounds, so 6 of them from the initial 12 of the test panel. We had 2 additional ones for which we have no multi-ion channel block published, but we kind of know that one's high risk and one's low risk. And this was done in order to sort of validate reproducibility by Kazuya Tsuruomi on a Sophion QPatch compact in Japan, and Dr. Patrick at Sophion in the US on a QPatch system. And so we have two different sites, 2 different operators, and 2 different systems, which gives us at least a little idea about reproducibility. We were pretty pleased with how this turned out. This is a typical sort of intermediate plot before to sort of the final evaluation. You have QNet here on the y-axis, and on the x-axis you have the times Cmax, and this is for dofetilide. And it's a plot of the actual FDA QNet risk evaluation for dofetilide using the Milne's protocol, as well, and then ours using the high throughput or through the automated patch clamp step ramp protocol. And you can see that over a wide range, we get a really nice agreement with the QNet evaluation, and also then with the Torsade Metric Score. They're very close, and their variability uncertainty is also very close. So that really gives us some idea that this is going to be easy. And then going back even further, we said, well, it's easier to get room temperature patches than non-room temp than physiologic temperature. Can we use that for this sort of analysis? And I'm very quickly just going to say, no, we can't use that for it. This is not suitable for analysis. And that's not surprising because it's a kinetic measure, and the kinetics are very different for drug binding as well as gating at room temperature versus 35 degrees C when you're looking at use-dependent behavior during repolarization. So here we have then the outcomes of the Sophion automated patch clamp versus the FDA's TMS scores. And you can see that there's a high correlation in scores, and really only one miscategorization, cisapride, which is, as you'll see in the next slide, surprisingly close. You can see that that's this little dot, A, you may be able to see it. It's right on the border between high risk and low risk, so it comes out very close. So the correlation over a wide range is quite close. We obviously focused initially on drugs that were near the border between high risk and low risk and intermediate risk, because we didn't want to be shooting fish in a barrel. We would start with the hard case and make sure we're doing that all right. The rest of these we'll probably fill in later with the CiPA-12. But it demonstrates really clearly that the step ramp protocol is a really efficient method for predicting risk once you've done a little bit higher quality control than you might for simple dose response curve. And it's really wonderful that Patrick did all that work with the optimization to get this high quality data that you can actually extract kinetic models from in the system. And obviously, physiologic temperature is absolutely essential, as is the careful exclusion of artifacts, which can set off model curve fitting, which is sensitive to any systematic sort of error, such as leaks or endogenous currents or electrode polarization. And so, CyberQ is available as a service. And it's been wonderful working with Sophion on this. I've been working most of my life combining models and experiments, and this has been a wonderful exercise in that, to see something so practical come out of it. And I thank you guys for the opportunity to present it.
Fantastic. Thank you so much for that insightful presentation, Randy. Beautiful to see sort of how that high quality, or physiological temperature data really feeds into your algorithms there. So we have a bit of time here before we conclude that session here, and can go over some questions. To start out with, there is a question here from the audience. I think, Randy, that would be for you to start with. Could you elaborate on the difference in results from room temperature and physiological temperature recordings?
Sure. I'm not sure quite how specific an answer I can give. They just didn't turn out. It really was not unexpected, and so we stopped putting a lot of effort into looking at it specifically. You have several problems there. First off, is the most important thing is the gating of the hERG starts to change with temperature. You have certain processes that are much more stable than others. In the gating there, your p-open changes, and because you're trying to look at things like trapping and use dependence, these are all kinetic problems. And to time where it's going to be during the repolarization of the action potential, you need to be able to actually effectively get the time dependence correct. And so if you're doing things that are happening, almost a factor of 5 or 6 times slower than where you actually want to be measuring them, you end up with answers that are fairly far off. Sometimes stay stuck much longer and then give you a wrong answer. Other times it'll become detached much faster because of the faster kinetic steps. So I hope that answers your question. It's a little, we can certainly go and talk about that in more detail later, and we can sort of maybe look at some of that data in more detail with you if you're interested.
I could also add, because I did have a slide that showed comparison of the room temperature and the physiological temperature that I ended up omitting. But when you record hERG currents at room temperature versus physiological temperature, the amplitude of that P2, that peak current, is much larger at physiological temperature. It is one of the most temperature sensitive channels I've seen in terms of the amplitude becoming 2 to 3 times larger with the higher temperature. Furthermore, the time constant of activation of the P1 currents is many times more fast. The P1 is not as important necessarily in this analysis, but it's much faster. But the rise time also of the P2 and the fall time is affected by the temperature. So as Randy said, it's not surprising. The kinetics are certainly affected by the higher temperature. And you also, though, are able to generate more accurate IC50s because you have a much higher signal to noise when you have a much larger current under the physiological temperature.
Fantastic. So another question here, Patrick, for you. You pointed out that the hERG channel expression is a challenge. Can you maybe elaborate? Are there strategies out there to increase expression, and have you used any of those in your experiments?
So my understanding, working with commercially available CHO and hERG cell lines, the CHO hERG cell lines can be particularly vulnerable to overconfluent growth. And if you allow the cells to become overconfluent through passage, through increasing passage time, you will lose expression and you will have very, very small currents. So you have to be extremely careful to make sure that the cells never surpass really 80–90% confluence, and that you're passing them very routinely. My favorite strategy anecdotally is to, you must, in my opinion, you always need to have the selective antibiotics present. Some people like to remove selective antibiotics through maintenance of a cell line. I think that can be okay depending on the channel. In my opinion, the selective antibiotic is always necessary and cannot hurt when you're keeping hERG cell lines going. But anecdotally, in my postdoctoral work, one of my colleagues made a cell line for a different channel, for a NAV channel, and instead of reducing the concentration of the selective antibiotic from the original selection concentration of nearly 800 micrograms per mil of G418 to the maintenance concentration of 200, we just kept it at 800, and we kept it there through a long, many number of passages, and those currents became like 20 to 25 nanoamps per cell. So I like to think at least it's possible that you could evolve a larger current in your cell line if you apply some selective pressure of higher antibiotics, but I have not tested this in our hERG cell lines. This is all referring to the CHO hERG cell line. My understanding from hERG cell lines is that they can be potentially a little bit more robust to this issue of overgrowth. However, in my experience, they tend to have a smaller current density, and they overall just had smaller currents, and we did not work to optimize them in this study.
Yeah, fantastic. Randy, so interesting to see sort of that the CiPA initiative, of course, brought us sort of like the STEP RAM protocol that is now sort of broadly being utilized. Prior to that initiative, I think the majority of people would be using STEP protocols. And I think, Patrick, you've shown a nice sort of historic example there in the beginning of the presentation. Has data from a STEP protocol ever been used in your QNet analysis?
Yes, we have used the STEP protocol, and we can do a variety of protocols in this analysis. The STEP protocols also provide quite a bit of information that's sufficient to constrain things in the same. Whether it's got as high a variability or not, we haven't done that sort of systematic analysis. But yes, the STEP protocol also does that, partly because you get a nice transient current when you're stepping back down to the voltage where you get the peak, as opposed to going through as a step ramp down.
That makes sense. All right, good to know. So we maybe have time for one more question here. So for compounds with multi-channel effects beyond the hERG, say late sodium or L-type calcium channel block, how does the weighting of each channel's contribution affect the TMS score in your model, Randy?
So the weighting of it is, of course, determined by the weighting of the physiologic currents as measured in the human heart that was developed to do the hERG model. So each one of those currents has a sort of a set basis based on ventricular physiology out of Yoram Rudy and his collaboration with Andras Vara on healthy human explant cardiac myocytes. And so that is how it's determined and what the weightings on those are. I think that answers the question. I'm not sure I completely understood it.
Yeah.
Be glad to talk more about that with offline. Yeah. As well.
I think that should be good enough. And we are also reaching the top of the hour here. That concludes our webinar. I want to use the opportunity to thank everyone for joining in on this webinar here today. We're going to make this available as a recording on our YouTube channel, so please check it out. There are a couple of more webinars that really touch on different other aspects of automated patch clamp. I'd also like to thank my colleague Jette Juhl, who really in the background put all of that together and really is the mastermind behind these webinars and ensures that everything works so well. Then finally, I want to point out that both Randy with his team at CytoCybernetics, as well as Patrick and myself, we will be present later this year at the Safety Pharmacology annual meeting in Montreal. So if you have any questions, feel free to reach out directly, or reach out and we can meet in person in Montreal in case you happen to be up there as well. So once again, thanks for joining today, and yeah, looking forward to continuing the discussion offline. Thank you.